Good morning, everyone. I am Dr. Tanya Fuqua, and I am a dentist and the director of child oral health under the Center for Children's Health at Cook Children's Healthcare System. So, welcome, and on behalf of the Children's Oral Health Coalition, and in partnership with the Department of State Health Services, their Oral Health Improvement Program, thank you for being here this morning and joining us today. This series that you all are joining is called Ask the Docs. We wanted to create an informal setting for physicians, dentists, nurses, healthcare providers, whether you're in dentistry or you're in healthcare and OBGYN, whatever the case may be, that you have a vested interest in making sure that your patients or the people that you touch are taken care of, and that barriers to receiving dental care or health care, especially while pregnant, can get access to care, and we can build relationships together to make sure that we can make those things happen. Conversations like this today are paramount for us to improve the coordinated care and referrals of pregnant teens and women. And yes, everyone, I said teens. I was remarkably surprised years ago to find out how many teenagers in our school systems that are pregnant. I, as a dentist, have a hard time getting kids to brush their teeth, much less all of a sudden to even think about a teenager being pregnant. All of a sudden, this is a child having a child. There's adult decisions, but yet this is still a child. Where do they fall in there? Well, guess what? We're here to hopefully answer some questions today. We have two wonderful experts, Dr. Combs, who will introduce shortly, and Dr. Bahari, which you will meet and hear about soon. They are both treating adolescent care, especially in this gynecologic area too as well. So today's topic is about transitioning from adolescent to adult medical and dental care. This is a timely topic because um, it's an International Adolescents Health Week. Wow, who would have thought we could have pulled this off to get this conversation during this particular week? But it's pretty awesome that we could. But because it is an important conversation to have with our medical and dental providers and engaging about adolescents in their medical and oral health care journey and during pregnancy, we need to make sure that these little babies are coming into the world in the best way that they can, and it starts with that mom. So we have a dynamic moderator who's actually been a speaker for us as well, and she is one of our own Cook Children's physicians. So we have Dr. Shanna Combs, gynecologist here at Cook Children's in our pediatric gynecology area. We are blessed. She is our one and only, and we are excited to have her with us. She's a busy lady trying to take care of all of our young women, our young teens. So strategies, we want to make sure that we are kind of talking about strategies to supporting pregnant teens and their transition from pediatric to medical and dental adult type care, information from doctor to teen confidential consults, parents consents, rights of minors, questions, all these things that it's like, as clinicians, we're like, oh, we can't talk to you. You're a teenager. You're not an adult yet. We have to talk to mom or dad. But as an adolescent, they actually do have certain rights. And actually, if they become pregnant, that's a whole nother level. So we're here to kind of talk about that and talk about the stigmas of identifying and barriers to care, tips for creating a teen-friendly environment as well. So without further ado, let me introduce Dr. Combs. She received her medical degree from the University of New Mexico School of Medicine in Albuquerque. She returned to Fort Worth, where she completed her residency training in obstetrics and gynecology at John Peter Smith Hospital. She has continued her practice in Fort Worth as an obstetrician and gynecologist since 2012. She's always enjoyed taking care of young patients. She did it and was consulted at JPS, and now we have her at Cook Children's, treating specifically our young children, our young girls. Dr. Combe is passionate for teaching. She works in medical education. She's worked in obstetrics and gynecology clerkship as a director with TCU and UNT Health Science Center School of Medicine, and is still involved as a preceptor and research mentor, I believe. And she has been an assistant professor for Texas College of Osteopathic Medicine since completing her residency. And I do have to always put in the plug, she is a child of a dentist. So she has an oral health path in her life, and she's very passionate about dental care. I was just in her office a week ago, and she has all this oral health information in the waiting room and in the treatment. So thank you, Dr. Combs, for being such a great advocate for oral health and connecting that to overall health. So without further ado, our moderator, Dr. Combs.
Good morning, everyone. Excuse me. Wow, Dr. Fuqua, you made me sound so fancy. Thank you. So yes, I am a pediatric and adolescent gynecologist, and yes, the daughter of a dentist. So I have grown up in dental clinics throughout my life. So greatly understand the importance of dental care to our overall healthcare. I always joke, you know, our mouth is within our body, and our whole body needs health. So, you know, just a kind of a brief introduction to our topic today, and really talking about kind of that adolescent transition to adult care. So I think it's one of those things that sometimes gets forgotten in working with teenagers, you know, as they start to get to their teens and 20s, they're like, oh no, what next? Also, they tend to be a relatively healthy population. So why do they need to go to the doctor? They don't have their well child checks and things like that as well. So I think it's super important that during the time, you know, when they're in those late teen years, are really starting the conversation of the importance of regular healthcare, regular oral care, because, you know, one of the things we always need to focus on is the importance of preventative care. And so even if nothing is going wrong, you know, it's nice to see a doctor or a dentist before things go wrong, so you have a relationship, as well as then being able to identify things early to prevent long-term outcomes as well. You know, I always point out one of the biggest things that a lot of people don't always remember is when somebody gets pregnant, they don't have a dental care anymore. And in reality, what we know about oral dental health and medical care is that it's super important to actually continue that, because there are now known associations with poor dental health can actually lead to poor pregnancy outcomes, as far as preterm labor and things like that. And then also kind of that preventative health aspect of, if you're taking care of your oral health during pregnancy, you're more likely to help your child do the oral health that they need as they grow and develop. And so, I think it's critically important that we really focus on finding ways to help our young moms and our young ladies to obtain good oral as well as overall health care, because we're all connected. We're not just a mouth over here and a body over here, but we're all one body. So I am pleased to introduce Dr. Mira Bahari. She has a primary board certification in pediatrics and a subspecialty certification in adolescent medicine from the American Board of Pediatrics. Excuse me. She completed medical school at the Sophie School of Biomedical Education, now the CUNY Medical School, and SUNY Downstate Health Science Center, where she also completed her pediatric residency. She then, that wasn't enough education, she needed more, so she went through a 3-year subspecialty fellowship in adolescent medicine at the Adolescent Children's Hospital of Los Angeles. excuse me. Dr. Bahari then moved to Texas in 2012, where she worked in adolescent medicine section of the McLean Children's Hospital at Baylor Scott and White until 2021, where she left to start a new endeavor of adolescent medicine consulting. She was also recently honored with a promotion to the rank of clinical associate professor at Texas A&M College of Medicine. So thank you, Dr. Bahari, for joining us, and welcome.
Thank you, Dr. Coombs. I have to say you are fancy, and I love that you've accomplished so much in your career. And I think we're kind of the same, right? Like we did our residencies and then we're like, no, we're going to sub-specialize and really focus in on this very interesting population of young women and adolescents. For me, I obviously see adolescent girls and boys, but I know that my best buddies have been OBGYN colleagues with an interest in this population as well. So I do have some prepared slides that I would love to run through with y'all, but I enjoy having discussions as well. And I hope that folks can just jump in and interject. And I also want to say a thank you to Dr. Fuqua, Dr. Cox, and Elaine for organizing all of this, and a shout out to my friend and colleague Blair Murphy, I think is Blair Williams now, and for getting us all connected. It's a small world of people who care about our young people, but we can accomplish great things. So first of all, a lot of people don't know about adolescent medicine, and I'll say we can move on to the next slide. So I do want to have a brief discussion of what adolescent medicine is. This is something that I'm learning that people don't know about after I've left the auspices of a children's hospital where everybody knows. So we'll talk a little bit more about adolescent medicine and how adolescent medicine folks can help y'all and your patients. And we'll talk a little bit about teen consent and confidentiality issues with some laws that are specific to Texas. And then we'll have some resources for more information. Next slide. Thank you. So adolescent medicine is a relatively young specialty. Looking back at the history, 1941, the AAP held the first medical symposium on adolescence. Interestingly, as I've delved into this, there was a movement to start some focus on adolescent health in the 1880s. But, you know, a couple world wars, pandemic, all of that stuff slowed that down. And so in the 40s and 50s, it really picked up steam as a subspecialty, with the 1950s as a time where Children's Hospital Boston had their first adolescent unit and training program. In 1968, the Society for Adolescent Health and Medicine was founded. At that time, it was called the Society for Adolescent Medicine. And it's only fairly recently that the name was changed to the Society for Adolescent Health and Medicine to reflect that we are truly an interdisciplinary, multidisciplinary, metadisciplinary, however you want to call it, type profession, where psychologists who are interested in adolescent health know a little bit of the medicine, and those of us who practice adolescent medicine know a little bit of psychology and dietitian work. So that's where we like to refer to ourselves as transdisciplinary. In terms of board certification, the first board certification was offered when I was an adolescent in 1994, back when I was graduating high school, and there's only 900 of us ever in the history of adolescent medicine since 1994. Some, of course, are no longer in practice and have moved on and retired. And there's 42 million adolescents in the US, 42 million. So there's not enough of us to go around. And that's part of why I and many others spend a lot of our time working with primary care pediatricians, working with dentists, psychologists, anybody who will be interested in helping young people and adolescents be healthier. Next slide. So there are 1.2 billion adolescents worldwide. When we think about that, that's the population of some of our more populous countries like China and India. Of those adolescents, about 2,000 are dying every day, 2,000. And they are mostly dying from preventable conditions. Road traffic injuries is what it's called in publications like The Lancet for the world, and even in our country, motor vehicle accidents remain the #1 cause of death. Obviously, throughout the world, infectious diseases still contribute to a high mortality. So diarrheal diseases and tuberculosis are causes of mortality, but interpersonal violence and self-harm are increasing around the world and as a major cause of mortality. And next slide. For our country, that is in the top 2 and 3, and actually suicide right now is in the top 2 cause of death for young people in our country. Number 4 is cancer. Number 5 is heart disease. So we see that there are lots of preventable things. And the way I like to explain this to folks is I can listen to a teenager's heart and lungs all day, all night, and that's not going to tell me if they're going to die from an accident. And it's not going to tell me if they're going to die from homicide or suicide. I really have to talk to them and know what the risks are. The other thing that isn't presented in this is that in the top 10, usually complications of pregnancy end up as a cause of mortality for young women in our country. I'll repeat that. For young women in our country, which has a very high income status and great healthcare facilities, but there is a disconnect with access. The graphic on the side just shows the breakdown that of the unintentional injuries, motor vehicle accidents are the most common cause of death. Next slide, please. And looking at causes of death overall globally, this is for all ages: ischemic heart disease, stroke, COPD, lower respiratory infections, neonatal conditions are the top causes of mortality. And when we see an adolescent, especially a pregnant adolescent, we have a chance to intervene on all of these. We know that there's a link between oral health and heart inflammation and conditions. We also know that if somebody's smoking, that will affect their dentition. And we have a chance to say, hey, I noticed your teeth are a little yellow. Have you started smoking? Whatever those signs are, you have a chance to just bring that up and not necessarily change their behaviors in that moment, but start that dialogue and move them from what we call pre-contemplation, not thinking that it's a problem, to contemplation, like, hey, maybe I should change some of this behavior. My dentist said something about it. Next slide, please. This is some data from the Youth Risk Behavior Survey. This is some of the 2017 data. They had lovely graphics then, so I like using those. And pre-pandemic data is what I like to point out. 32% of the young people who took this survey reported signs and symptoms of depression in the past 12 months. And this survey is one that's given to high school students every 2 years. So I call this the tip of the iceberg data, because when you think about it, the kids who are highest risk aren't showing up at school, aren't taking that survey, probably dropped out and have other challenges. So this is just the tip of the iceberg. In terms of physical activity, we know that about 47% of kids are getting the recommended amount of physical activity for 5 or more days of the past 7 days. And just click ahead. Should be, yes, sexual activity. So good news here is that this number is going down a little bit, but it's not where we want it to be. So in terms of high school students who ever had sex, 40% reported ever having had sex of those who took the survey. And again, the highest risk group probably isn't taking that survey. So we've got some work to do. And if you are seeing teenage patients, chances are they're having one or more of these risk factors. And it's a great time to intervene when you see them for their yearly checks or some of their orthodontia. Next slide. The biopsychosocial model of health is one that has been ingrained to me since the first day at Sophie Davis School of Biomedical Education, and it's one that is catching on in terms of popularity. This model says that our health, as well as illness, is determined by biologic factors, our genetic predispositions to diabetes, to cavities, whatever it might be, as well as social factors. Everybody's eating candy, nobody takes time to floss, flossing isn't cool. It's the psychological factors. I'm so depressed, I am not doing my activities of daily living, and I'm not brushing my teeth and taking care of myself the way that I should. So all these factors can convene to influence health. And I always think of this, the adolescent doc who trained me at SUNY Downstate in Brooklyn. She would always say, you know how folks say the eyes are the window to the soul? She felt it was the teeth. And she's right. You know, there's a lot that we can tell about how people are feeling about themselves and how they're projecting themselves to the world based on their dentition. So that is something that I think resonates, hopefully, with you guys. It's stuck with me all these years. Next slide. So adolescents in our country are only about 13% of the population. However, they are 100% of our future. Everything we do in this age group can affect them further on. And this is why I love it as someone who cares about prevention. I have only met one person in all my years of medicine who started smoking in their 30s, and that was someone who had a delayed adolescence because she got married very young and then got divorced in her 30s and had her rebellious phase. Most people, they start their unhealthy behaviors or their healthy behaviors in adolescence. So we can influence their health not only now, but for when they're 80, 90, and beyond. The normal developmental pattern for adolescents provides a unique opportunity to influence the life course of the young person, their family, and their friends. And when we think about a pregnant adolescent, as Dr. Fuqua mentioned, we are affecting not only their health now, but their health of their child and the future. Next slide. So sorry that it's a little off on the heading there with the formatting. But this is just to give you an example of how few of us there are. These are the adolescent medicine specialists in the state of Texas. And as you can see, most young people would need to drive more than 80 miles to find an adolescent medicine specialist. These are also actually all of them are affiliated with academic centers, and I can probably tell you exactly who's in every single location. I like to tell people, not everybody needs an adolescent medicine specialist. You know, we are a subspecialty, and just like not everyone needs a neonatologist, not every teenager needs an adolescent specialist. But if there is a child who's higher risk, who has maybe some eating disorder issues, some anxiety, depression, that is more than what can be managed in primary care, but not necessarily needing a psychiatrist, or even in some cases where the psychiatry wait is significantly long, adolescent medicine can jump in. As I mentioned, I work very closely with OBGYN colleagues wherever I go because we handle a lot of reproductive health issues as well. And most of the patients that a subspecialty adolescent medicine person is seeing have a combination of all of these issues. Those are usually my favorite patients, where there's some type 1 diabetes, plus possibly an eating disorder and some depression and some menstrual irregularities. I love those complicated patients, and I know my colleagues in these areas feel the same. Next slide. So this is just to give you an example of the disparity between another age-based specialty, neonatology. And certainly, I'm not saying we don't need any fewer neonatologists. We actually need more. But they're doing a great job at doing their job, and the pediatricians are doing a great job at being pediatricians, and family medicine folks are doing the primary care as well. And we're going to have more and more adolescents. And as has been stated by the American Academy of Pediatrics, we are currently in a mental health crisis for our young people. And we know that we need really all hands on deck to help young people get plugged into the care that they need. Next slide. So adolescent health needs are increasing, and even though some progress has been made, we are seeing an increase in the number of high school students who are reporting signs and symptoms of depression and suicidal ideation. There was a 51% increase in young women aged 12 to 17 requiring emergency care for their mental health. And again, these numbers don't account for the significant increase in COVID. That 51% increase was part of what we saw with COVID, and every single pediatrician, family medicine person I know, every children's hospital has had an increase in admissions for suicidal ideation and self-harming, as well as eating disorders. That's the other significant increase we've seen during the pandemic. Next slide, please. But change is possible. This is one of my favorite slides. And yes, I know you feel the same way, Dr. Combs. We know that with collaboration between research, healthcare professionals, legislators, schools, and community organizations, we can have improvements in health outcomes. And as you can see, in the state of Texas, we have had a significant decrease in teen pregnancy and childbirth. And the rate back in the 80s, late 80s, when adolescent medicine was just becoming a board certified specialty, our rate was 75 per 1,000 young women aged 15 to 17, and now we are at 18. A combination of efforts from folks like everyone here and beyond is what made this possible, and we can certainly get that to a place that's even better. Next slide. So we're going to talk a little bit about good old consent and confidentiality. Next slide. This slide is one that I liberally use and was taken from Adolescent Health, a guide for health providers, and from the Texas Health Steps program. And it basically shows the importance of adolescent medicine and that focus, that change in focus from parent and doctor in childhood as the primary relationship to a parent-patient-doctor relationship as the young person is able to engage in his or her care a little bit more, to ultimately a patient-doctor relationship. And I let folks know when I talk to teenagers alone, which I do routinely for at least a few minutes, starting when they're like 10, 11, and in some cases even younger. I let the parents know I'm doing this for two reasons. One, to ask all the confidential questions that folks expect us to ask and find out if there's things that they just didn't feel comfortable bringing up with a parent in the room, but also to set them up for success when they are 18, 19, 20, and so that they're not shell-shocked when they go into an internist's office and things are moving very quickly and they've got to answer all of these questions and know what meds they're on and all of this. So when you're seeing patients, as young as possible, let them know what you're doing, why you're doing it, and let them have a chance to engage in care. Next slide. The Society for Adolescent Health and Medicine, the American Academy of Pediatrics, the American College of Obstetrics and Gynecology, the American Medical Association all agree that confidential care of adolescents is essential to their overall health, and parental consent or notification should not be a barrier to medical care. And in general, Texas law supports this view. Next slide. This is a standard definition. Everything has a legal definition. An adult is a person under 18 years of age who is not and has not been married or has not had the disabilities of minority, that's what it's called, removed for general purposes of a court. So instead of emancipation, we usually say removal of the disabilities of minority is the official technical term. A person who is not a child is considered an adult. Very confusing. This is why I'm not a lawyer. So basically what they're saying is if you had a 17-year-old, he or she got married, they can't go and then they get divorced before they turn 18. They don't go back to being a child once they've gotten divorced. And same thing with service in the military. Again, hopefully we don't have too many people serving in the military at 17, but if that were the case, they would still be an adult once they've crossed that threshold. Next slide. And so the formal process of emancipation, which is a formal process in the state of Texas and not a formal process in some other states, involves the removal of disabilities of minority. And it is a formal court process, meaning the teenager and or family need to go before a judge, and they need to have Texas residency. They need to be 17 years old or at least 16, living apart from their parents, managing conservator or guardian, and self-supporting, maintaining their own financial affairs. So that means that if they're living in an apartment that's paid for by grandma, they are not considered independent and managing their own financial affairs. They need to be self-supporting. And a copy of the court order is proof that the child is no longer a minor under the law. That is, that they are emancipated. Most young people you're seeing aren't going to have this unless there was a significant change in their family life or some other type of condition. But it is something like, if somebody comes up to you and they're like, I'm emancipated, you can ask for this paper and that will let you know if they are legally emancipated or not. This allows that young person to like rent a place to live and all these other things. It's really a catch-22. So there's not very many people who meet criteria. Next slide.
Dr. Bahari.
Yes, ma'am.
I wanted to see, can you comment about what happens when they're pregnant?
Yes, so that is definitely one of the things that I did as a true false, but we can jump into that right now. Is somebody emancipated? Well, yeah, this is ways to become an adult before 18, getting married, or serving in the military. Is pregnancy on this list, y'all? Two. So just being pregnant does not make you emancipated. And I can tell you, I've worked in a variety of settings within the state of Texas and talked with colleagues in other places. And lots of our front desk people are putting in a little thing. Patient is emancipated. They are pregnant. And that is not true. Legally, they can consent to some aspects of care, but not everything. Next slide. So this is the false. They are not emancipated, but they can consent to their health care as it affects the pregnancy. So what does that mean? If they are actively pregnant, they can consent to their dental care if that will affect the health of the pregnancy, which we've all been pretty clear that it does. They can consent to vaccines that they might need for pregnancy. If they were found to have an infection during pregnancy, they can consent to treatment for that. In the state of Texas, as I hope everyone knows, parental notification is needed for a termination of pregnancy. I bring that up for several reasons. One, obviously, folks should know about that if someone is seeking a termination of pregnancy. But more importantly, if somebody tells you they had a termination of pregnancy and parents weren't notified and they did not go before a judge, I worry about the person who provided that termination of pregnancy and potential health risks for that young person. It was certainly a situation I saw in a clinical practice where we had a young lady who was unfortunately given some pills that resulted in a termination, and those were not provided by a medical provider and was actually part of a trafficking situation that was going on. So we had a chance to intervene because of that. So yes, they can consent to some care, but not everything. Next slide, please. You have to have a parent's permission in order to treat a teen for an STD. True or false?
Can I answer?
You're not allowed to answer. You knew this. This is our bread and butter, right?
Yes.
Anyone want to venture an answer?
Y'all can put it in the chat box or just think it in your head. That's fine. This is making you think.
Correct, Elaine. So yes, it is false. We can treat for STDs as well as other infectious diseases without parental permission, and that falls under public health statute. So interestingly, I had a colleague look it up, and anthrax and things like that fall under there too. So if you have a patient with anthrax, go ahead and treat them. Worry about parental notification later.
So I have a question about that, Dr. Bahari.
Uh-huh.
say that I have a 15-year-old daughter who,
Yes.
you know, as you said, had those private moments of conversation with you. It determines, you know, it leads to a discussion testing there's an STD. So you can prescribe her a medication without me really knowing. And if she doesn't want to tell me what it's for, I can't find out. Is that right?
Yes.
Wow. Okay.
Yes. And it comes from, you know, the public health perspective of trying to prevent the spread of infection and disease. Now, that being said, and Dr. Coombs can let you know that all of us who work with teenagers and young adults feel the same, that it's important to have a trusted adult involved in care. And we hope that that is the parents, but unfortunately, we've also experienced the situation where parents or guardians, whether that's biologic parents or someone in foster care, have unfortunately been abusing the young person or trafficking the young person. And in that case, even if we tell them, it doesn't necessarily mitigate the risk. So we want to make sure that it is a trusted person and that we are being that ally in a situation where they can get care. Yeah.
One of the things I always kind of point to this, because I know I've had parents actually ask me about, like, you know, maybe their daughter, obviously I work with just girls, reached out to them and said, so I tested positive for this. And then the parent got upset because they weren't told first. And I have to kind of go, you know, that's one of the few times where I'm sorry, it's my legal responsibility. Like, I'm not allowed to tell you unless your daughter gives me explicit permission to. Because unfortunately, also, you know, besides the sad stories of children being abused in their home environment, you also have to take into consideration that sometimes if a parent does find out that they are sexually active in a controlling environment, concern for abuse, not necessarily sexual, but, you know, mental or physical abuse, because their child was sexually active, and restrictions that come from that. So while it sounds scary, and I always talk to kids about, like, if there's, you know, do you have somebody you can talk to? Do you want to talk to your parents? Or even offering the option of, like, if you want me to have a shared conversation. So, like, the child's not having to do it alone, but, you know, I can help support them in discussions with their parents. But yes, essentially it is a public health issue, is if we, if children don't feel trusted to talk to their physician or their dentist about these things, then they're not going to get tested and they're not going to get treated. And then you spread disease even further. So, you know, kind of really talking about, like, the greater good, so to speak, of getting them the treatment that they need.
Yes, well said. And, you know, I like to remind parents, because I know parents always get scared. They're like, oh my gosh, like, this could be going on and no one would tell me. We are all mandated reporters as well. So if we feel that there is, or even suspect the tiniest bit of suspicion that there is abuse going on, then we would, of course, need to report that. Age of consent in Texas for sexual activity is 17. We do have what's called the Romeo and Juliet clause, but that is more for the legal people to sort out. And as I tell my residents, you know, and medical students, when in doubt, report it out. So if you're not sure, report it, file it, and, you know, go through the proper channels. If it's someone in training, I have them talk to their attending, or that's a situation where you could talk to somebody like me or Dr. Combs, and we can help guide you on what the best way to report and what other information you need is. But we want to make sure that our young people are, number one, safe, and we're not doing any harm. And certainly having someone go untreated for an STD would be causing harm. And also with parental notification, I think there's a logistics issue. I love that you picked a 15-year-old as an example. You know, yeah, you can have a hardship license at 15, But in reality, are you going to go to the pharmacy and pick up your med and take it? And, you know, if that person is taking the medication, heaven forbid they have an allergic reaction, somebody's got to know what they took and what's going on. So those are all things that we want to consider. And we do encourage young people to talk to a trusted adult as much as possible. Next slide, please. So this is the actual law that states that we can treat, as a physician or a dentist, that we can treat young people for infectious, contagious, or communicable diseases, including STDs. And certainly there are episodes of gonorrhea and technically chlamydia causing pharyngitis as well. So it is something that I know dentists see. And I know in terms of the whole HPV thing, that's another area where the STD world and dental world coincide. So I hope that folks are encouraging their young patients to get the HPV vaccine, and looking out for any signs of oral STDs. Next slide, please. And this is one of my favorite, but also sobering slides. Rates of gonorrhea and chlamydia in the different states. And this is data from 2018. But as you can see, in Texas, we have about 629 cases per 100,000 people age 15 to 24, and 3,555 cases of chlamydia per that age group as well. That is the highest age group, and yeah, we can do better. So next slide. Expedited partner therapy. So this is something I like to let everybody know about, and I hope some of the dental providers on the call can help verify this for me. As a physician, we can treat the partner of somebody who's positive for an STD without actually seeing that patient in our office. So let's say I have that 15-year-old young lady who is positive for chlamydia. I can prescribe for her partner or partners without seeing that person. The insurance of my patient, the one that I saw, will probably not pay for the partner's treatment. So they would need to get it either through the discount drug or through their own insurance. And we do like to keep records for that. The Department of State Health Services has some great resources in terms of how to track that, letters that you can give to your patient to give to their partner. And I imagine that this would apply for dentists as well. I don't know how often y'all are able to treat gonorrhea or chlamydia in your practice or pick it up, but that's certainly something that could be done. And I always like to say, I don't know what the deal is with South Carolina. Like, why did they prohibit this? But just something to keep in mind if you go to South Carolina. Next slide. So solutions, we'll pop over to the next slide. This is part of what I'm doing with Adolescent Medicine Consulting. We're doing some workshops, so small group workshops for physicians and other healthcare team members on issues such as anxiety, depression, eating disorders, menstrual problems, contraception, and more, as well as educational sessions like this, talking about adolescent-friendly office and having a practice set up so that these conversations can happen in your office. And also doing some research and publications, program development, as well as tailored services to help your practice be more adolescent friendly and set to see adolescents. Next slide. And that is all of my contact information right there.
Excellent. Thank you so much, Dr. Bahari. Always love talking about the teen mind and the teen way of life. So one of the things is kind of talking about with consent and confidentiality, and how do you set up a visit with a teenager? What do you think is kind of your best practices when you're working with adolescents?
So that's a great question. And as a pediatrician, I love anticipatory guidance. So giving people a heads up about what's coming down the road. So at that 9-10-year-old visit, or whenever you start seeing the signs of puberty happening for that young person, letting the parent know, hey, puberty is on the horizon. I will be spending more and more time talking to Timmy one-on-one or Janice one-on-one during our visits to help set them up for success when they are an adult. Some practices choose to have a transition letter explaining some of the things that will happen at those 11, 12-year-old visits, and then also explaining that at 18 or 21, whatever it might be for their practice, that they will transition to either a family med or internal med person, depending on the needs at that time. So spending progressively more and more time alone with the young person. And if it's somebody I'm seeing in continuity, that's usually easier because, you know, they know me and we have a trusted relationship as parent and provider. But if it's a first time visit, sometimes I might spend just 1 or 2 minutes alone with that young person asking the key safety issues or key issues that might be related to their chief complaint.
How do you try to set up teens to kind of talk about their own health? I think that's one of the things, even with the parent in the room, when they come to see me, obviously as a gynecologist, I'm like, so tell me about your periods. And they like look at their parent. And I'm sure just with general care in that population. So how do you encourage teens to kind of take ownership of their health as they're kind of making that transition to adulthood?
That's a great question. Doing exactly what you said, like addressing some of the questions directly to the teen, to the patient, letting them know that this is their healthcare visit. And progressively, as they get older, mom or dad is in the supportive role to provide some information. And usually the teen can say something about their chief complaint there, but when we get into some of the other questions like family history and things like that, to reach out to parents. And depending on how close we are to that age of transition 18, I might ask the teen first. And then when they give me that deer in headlights look, I'd be like, so this is part of why we still need your mom and dad here, is to answer these questions. But just know that in a couple of years, we're going to expect you to know some of these answers too. So yeah, the body language and making that safe space and letting them practice, because the reality is, I mean, y'all have been to your doctors. When you go to an internist, it's, you know, very, very quick and efficient, and they're not going to stand there while a teen is looking at their parent and they're having all their little side conversations. They don't have time for that, you know.
I'm going to interject here just a minute and add the dental portion of this. I do want to say that we have a unique position in dentistry in the fact that I think dentists set it up from the beginning as a young child. Parents don't come back. I don't know if y'all remember. Most, it used to be all the time, kids came back to the dental chair by themselves. Parents stayed out in the waiting room. A lot of that was because kids didn't help the behavioral, the getting them to focus on us and listen to us. Parents were instilling their fears of dentistry to their child, so their child was acting out. So used to be all the time was a standard of care. The child came back by themselves as a young one, right? You know, it didn't have to be a teenager. That has changed over time because enough parents, you know, hovering parents said, no, I need to be with my child all the time. And so that's changed. And basically our rules are, you know, I always laugh if a parent asks and I say, oh yeah, you can come back. As long as you behave, mom, you can come back. Because I want to be able to have the conversation with the child themselves. I don't care if they're 5, 6, 7, or 8. I want them focusing on me and not always, like Dr. Combs already said, you ask a question, they look at parent, like you answer it, right? Or you want to know from the child and you want them to start taking that ownership. So I will say dentists are good as a young to kind of bring them back a lot of times and want to have them back by themselves and then say, okay, we're going to go get mom or dad and we're going to have them come in. But I think where we go bad is when they become teenagers and we die. Like, I think dentists then are like, I don't know how to have these hard conversations. You know, But if I see bleeding gums, and I've seen this kids since they were little, and their gum tissues were been perfectly fine, and now all of a sudden they're just like bleeding, gushing, and it's a female, I'll say, "Are you on your cycle today? Are you on your cycle right now?" Because that hormonal change makes them look. And if they're like, "Yeah, and I'm bleeding really bad, I'm having a really hard cramps," I'm like, "Oh, okay. Well, then that explains the gum tissues." But most dentists aren't comfortable asking that. And I don't understand, much less not asking about HPV vaccine and that kind of stuff. But there are a lot of things that we can see in the oral cavity that will help us to have signs or seeing that if a child never looked like this and now they do, something's different, something has changed. If their oral hygiene is bad and it used to be great, maybe they're depressed, maybe they're stressed, maybe something else is going on. Gum tissues never used to look like that, and they're always like this. I'll see them in 3 months, it's still like that, but their hygiene is great. Why are their gums like that?
Well, and Dr. Fuqua,
Right?
that was something that you're kind of leading into something that I was going to ask Dr. Bahari while we've got her. Just like she said, we're seeing a change in a patient and maybe we're suspecting some mental health kind of issues. What is the best way to bring that up to a patient, whether they're back there in the chair by themselves or the parents sitting there? Like, what's the best way to address that without, I don't know, somehow accidentally making it worse by putting a spotlight on something that they thought they were hiding? Like, how do we navigate that conversation?
That's a great question. Yes, that's a great question, and I love it because I think this is the art of healthcare, and why we all haven't been replaced by robots yet, and we won't be, because you've got to figure out your rapport with that person, and it might be that it's your style to say, as your dental provider, I care about your whole health and your complete well-being. I've noticed some changes in your dentition or in your gums. Has something changed for you? Are you brushing regularly? Are you sleeping okay? What are some of the factors? Have you changed your eating habits? And the research shows that if we ask about suicide, it actually doesn't increase the likelihood of the person thinking about or engaging in suicide. It actually gives them that rope to pull themselves out of that situation in a way to get the help that they need. And citing some of the data, I just went to this talk the other day and they said that, there's a mental health crisis and a lot of young people are struggling with the pandemic and with everything that's going on. How are you coping with that? Whatever it might be to break the ice with that person. And they may not talk to you. I think that was one of the lessons that I learned in practice. It might not be that first visit, but when you open that door, they know that you're a person that they can come back to and bring up that conversation later on, and that you will check in from time to time. Other things that I think are having like little brochures and handouts and having maybe like the suicide hotline number somewhere in the office, because even if they're not going to talk to you about it, they'll see that number and they can know that there is a place to get some help.
And teenagers will take pictures of things that they, right?
Yes.
So I've learned that too, that I've seen someone like take a picture of something that I had in the room or whatever. So that's a really good point. And I do want to say, Dr. Combs and Dr. Bahari, so Dr. Stokely just asked a really great question, but one of the things that I have found is you can't ask a general question of how are you doing? Or I've noticed something changed. You have to actually go to the pointed question, even if it's uncomfortable for us. Is that correct? We're not going to get that answer if we don't ask it specifically, because
Fine.
stuff.
Yeah. I call it the teenage, I'm fine, I'm okay.
Yes.
And so, I think when talking, using kind of those checks of like, I noticed that your teeth aren't looking good, or you've kind of changed how you look lately, and kind of delving into that. And then the other thing I always point out is that it's okay to not be okay. I think that's become one of the biggest things right now. And, yes, we're in a mental health crisis, and especially our kids. We've all suffered from the pandemic, but I think they have, I'm very intrigued to see what is going to come out over the next few years of finding how our kids have handled this, because I think they are really struggling. And then the other part of it is normalization. So just like I say, oral care is part of healthcare, mental health is part of healthcare. I'm always like, your head's not over here and your body's over here. Like, we are all connected. And if this isn't working so hot, then the rest of our body isn't working so hot. So really just trying to focus in on that normalization. And just like Dr. Bahari said, the first time they may not say something, but the next time they come in, they go, I'm glad you asked me. I actually wanted to talk to somebody about that. Or, it allows them to open the door, or even if it's not with you, but with somebody else, another trusted adult, or, school counselor or teacher, or somebody that they felt like, somebody noticed, and maybe I do want help, and reaching out. I think that's super important. Awesome.
I just want to stop and ask Kim. I haven't been really checking the chat box, but for anybody that is on the call, we're getting down to the last 6 minutes that we're committed to this. And I want to be very conscious of our time. So please, if anybody has any questions, drop that in the chat box at this time. We'd really appreciate it. We've got some really awesome experts here on the line today, and let's ask them so that we can all be out there helping this population to connect oral health with overall health.
In the meantime, I've got another question, if that's okay.
Yes. Yeah.
So you with our program here at the health department, we always like to talk about how pregnancy is a teachable moment, right? Women may have never cared about their health before then. All of a sudden they think about quitting smoking, so forth. Do you see that same spark in pregnant teenagers when they're that young, or not?
So I would love to hear Dr. Combs' experience on this as well. I will share my experience, and I will say it varies. There are some teenagers who are pregnant, and it was a semi-conscious choice, or maybe a fully conscious choice, and they are motivated to care for themselves and their future and think things will work out well, and it usually does in that situation. And there are, unfortunately, we know about 1 in 4 young women who's experienced some form of childhood sexual abuse. And for those young people, the entire pregnancy experience can be triggering and can put them in a downward spiral of depression and some PTSD. So I think it varies. And just like, one of the things we ask our trainees to do when we're asking a sexual history is not to presume heterosexuality and not to presume certain activities. It's hard, especially as a pediatrician and loving children, to not presume that this is a happy pregnancy, and that they are still in a relationship or still want a relationship with the father of their child. So yeah, it kind of varies. So for those, but if again, they've chosen to continue pregnancy, and whether that pregnancy is going to be given up for adoption or they're going to parent, encouraging them to take best care of themselves and others in that moment. Yeah. Dr. Coombs.
Yeah, I definitely would say it's definitely a little bit of a different population depending on the circumstances of the pregnancy itself. And so that being said, they are engaging with healthcare more often, obviously, in pregnancy, or, you have your every 4 weeks, and then every 2 weeks, and then every week. And so I think it is an opportunity to talk to them more so about overall health. Whereas, when in a traditional kind of adolescent medicine model, they might be seen once a year or every 2 years. And so it is an opportunity to try to kind of focus in on health and things like that, regardless of whether they're keeping the pregnancy or not, or giving the baby up for adoption or not, that focusing in on that kind of overall health picture during that time, and using that time as education for that.
Well, this is a great way to kind of get to wrap things up. You made a great point, Dr. Combs, just right there at the end, saying that the opportunities that we have and why we're here together today as the medical side, bringing the medical and the dental side together to have these conversations, is because every time any of us see a patient, whether they're coming in from medical, you're seeing the mouth, you're seeing them talk, you may see signs or symptoms or whatever of something going on that can lead you to those oral health questions. And if a patient is in a dental office and they're seeing these oral health signs, symptoms, things going on that's different, we should be helping them connect the dots for them for that medical side, for that whole body health, right? We've got to go there. We're never going to make change, right? We're never going to make change. And to me, this is considered a public health issue when we cannot look at the body as a whole, right? So I really, really appreciate both of you today, your insight that you brought, a lot of things that make me go, and you answered some questions that, I really didn't know myself about, treating this age group and population and adolescents and the rights and all that good stuff. So thank you for that. You all are remarkable. I love it. Thank you for your contact information. If anybody has any questions or concerns, you got this information to be here today because of Elaine Vivens, the coordinator for the Children's Oral Health Coalition. Please, anybody feel free to reach out to Elaine. She will be happy to connect you with one of these two awesome docs, or Dr. Stokely herself with the Department of State Health Services for anything else. So in closing, besides saying thank you to all of you for your time and your efforts, your energy, and your passion for this topic. Dr. Stokely, do you have anything you want to say on behalf of the Department of State Health Services before I close us out?
No, just thank you to our speakers. I mean, this is really helpful, and we appreciate you taking the time from your schedules to do this. And thank you for the work that you do.
I want also for everyone to go ahead and mark their calendars for our next Ask the Docs session, which will be May 24th from 5:30 p.m. to 6:30 p.m. So a night one. And the topic will be maternal depressions, signs, facts, and resources. Our presenters will be Drs. Lisa Elliott, and Drs. Kiera Carter. So we're excited to have them talking about mental health and oral health connection, signs to look for when screening for maternal depression, and resources available and all that good stuff. We've hit on some of that stuff today in teen adolescents. So we're going to go in kind of on, continue that further on and dive into that a little bit more. Thank you, Dr. Combs, for moderating. Thank you, Dr. Bahari, for sharing your great information with us today. I appreciate all of you. Thank you, ladies. Thank you, everybody, for being on the call today, and everyone have a great day.